Good evening and welcome to the first Trauma Care webinar. My name is Andrew Umrod and I'll be helping facilitate the webinar tonight along with my colleague Sarah Harris, who is in the background. And so tonight's webinar, The Changing Face of Major Trauma, is presented by Professor Sir Keith Porter. Before we go any further, for those people who've never taken part in a webinar before, we can't see or hear you at this point. You can only see our screens, and very shortly I will hand you over to Professor Porter and you'll be able to see his presentation. Just a very quick disclaimer that any learning that has taken place or does take place from tonight's webinar should not solely be relied upon to inform practice or indeed allow practice outside your individual scope of qualification. So just bear in mind any information that you do learn from tonight, you must retain and use it as part of your decision making within your scopes of practice. One of the things we're looking for tonight is to drive some new members towards trauma care. Lots of great benefits there. I'm not going to go through that list because you will get access to this recording after the webinar presentation, but there's lots of great benefits. And we've also reduced the price so you can pay monthly now. So as a student, it will be £5 per month. And as a full member, it will be £8 per month. And one of the great benefits now is you will have access to the trauma care recordings from the conference, so as well as the webinars and the certificates you get from tonight's webinar. You'll also get access to the recordings from Trauma Care 2017. If you are on Twitter, you can follow us by using hashtag TraumaCare17, and we will be putting some snippets on there throughout the presentation. And so hopefully you'll follow us on there. If you don't follow us already, please do so, because what we will do at the end of the webinar tonight is we will pick a random winner, whoever is the most popular tweeter stroke retweeter, and we will bob you £100 worth of trauma care vouchers that you can use for up and coming courses. And so I'm just about to hand over to Professor Porter. Are you there, Professor Porter?
I want this evening to share with you the subject of the changing face of major trauma. Some of you will be aware that trauma has changed in the last decade or so, but probably not to the extent that I'm actually going to share with you this evening. So I expect many of you would regard major trauma as being very much what you can see on the screen now: high-speed RTCs, multiple casualties. And if you ask the general public what their interpretation of major trauma is, I'm sure that would be their answer. And certainly, traditionally, it's been a disease of the young. It's been frequently males and commonly associated with road traffic collisions and interpersonal violence. That is all changing, and you're now looking at the face of new major trauma. 38% of all injury-related deaths occur in individuals 75 years old and above. Let me share with you a case history. This is at Queen Elizabeth Hospital, Birmingham, and this is an 85-year-old car driver who was estimated involved in a front-end collision at 50 miles an hour. He was wearing seatbelts, the airbags deployed. He was able to self-extricate, and his observations are, as you can see: blood pressure 128/84, RESPs of 18, SATs of 91%. He had a GCS of 14 and was noted to have repetitive speech. He had a cut to his nose with deformity. He had a past history of atrial fibrillation for which he was on a non-reversible oral anticoagulant. And our ambulance service colleagues made a diagnosis of head injury, a nasal injury, and a probable soft tissue injury to his ankle. This is what his CT traumagram showed. Now, CT traumagram is a scan from the top of the head down to below the hip joints. And as you can see, he's got extensive injuries. He's got head trauma with subdural and subarachnoid bleeding, a nasal fracture. He's got previously undetected clinically bilateral rib fractures, a pneumothorax, a hematoma around his liver, an acetabular fracture, other pubic pelvic fractures, and an ankle fracture. So when we analyze the pathway for this patient, firstly, he did not come in as a trauma alert. Secondly, he received routine ED management, which actually often involves several hours delay depending on the effectiveness of the initial triage. There was delay to him having a traumagram. There was a delay to giving his Beriplex to influence his oral anticoagulant. And 2 hours post-arrival, he became hypotensive. He went to critical care. He progressively deteriorated. He developed multi-system organ failure and died within 48 hours. So these patients, which we tend to call silver trauma, are a significant factor, and I'm sure most of you spend an awful lot going to the elderly who have fallen from a standing height. I'd just like to do a small maths lesson with you at the moment and just explain injury severity scoring. For some of this who may use it on a regular basis, I apologize, but for everyone else, I just want you to get a grip on what in fact constitutes major trauma. So injury severity score is derived from the American College of Surgeons abbreviated injury scale, and basically for a body area you can score an injury from 0 to 6. If you score 6, that means the patient is dead. Decapitation would qualify as a 6. So we're really interested in 0, no injury at all, to 5, and you score the patient's injuries. And you take the you may take the most serious injury from 3 body areas, and then you square the coding we've given. So if you had a head injury that scores 2, you square that, that scores 4. A chest injury that scores 3, square that, scores 9. An abdominal injury that scores 4, square that, you make 16. So your patient has an injury severity score of 29. And as I'll come back to, life-threatening trauma is an injury severity score of greater than 15. Very important in the context of what I'm going to talk now a bit later on in more detail about the elderly, is that it's possible to score an ISS greater than 15 with a single system injury. And commonly that's a head injury, where if you score a 4, you square that at 16, and you immediately have a life-threatening head injury. So just go over this again. We regard life-threatening trauma as an injury severity score of greater than 15, and a life-changing injury of an injury severity score between 9 and 15. In the UK practice, we would like to think that those with an ISS greater than 9 go to major trauma centres, and certainly those with injury severity score over 15. So we have a big problem, and the biggest challenge to healthcare in the country at the moment is our elderly population who, in relation to trauma, have injuries. Recognition, appropriate treatment, and then, of course, the social care package when you get towards hospital discharge. But why is this a problem now? Well, it's because patients now have better health. More people are looking after themselves. There's better mobility. More elderly people are independent, and overall, despite the pressures on healthcare, there is a higher standard of healthcare delivered. Parallel with this is, as you get older and you get frailer, then many patients do very well, and then perhaps at age 85 develop frailty, and with frailty comes increasing falls, more significant injuries, decreased physiological reserve, and with that, a limited potential for recovery. I'd like to share with you 2 landmark papers, if I may, and these are a combination of authors from the emergency department in Plymouth, Tony Kehoe and Jason Smith, and colleagues from the Trauma Audit Research Network, Antoinette Edwards, David Yates and Fiona Leckie. And this is a paper well worth scrutinizing, and I've taken my title from this, as will become apparent in a moment. So the TARN network have used their database and used data from 1990, or end of 1990, beg your pardon, 1990 to the end of 2013. And as you can see, that is over 116,000 patients. And they've looked at it in relation to the age, gender, mechanism of injury, and the percentage use of CT scanning. divided into age groups, as you can see, 0 to 24, 25 to 49, 50 to 74, and the over 75s. And mechanism of injury based on road traffic collisions: falls greater than 2 meters, falls less than 2 meters, shootings and stabbings, and a small ragbag of others. Now, here are the results of those with life-threatening trauma. And the first thing I think to note is that in 1990, the mean age of our patient with life-threatening injuries was age 36, and come 2013, that's risen to nearly 54 years of age. When you look at the individual groups, and you look at the under 25s in 1990, that was 39.3%. Come 2013, that's down to 17%. But very importantly and very relevant to tonight's discussion are the over 75s, where in 1990 that accounted for 8.1% of patients, and in 2016 that's risen to 26.9%. So a very significant change overall. Male-female ratio you can see for yourselves, and in relation to this study, then more patients had CT scans in the 2013 series than in 1990. When you analyze the mechanism of injury, you will see that comparing 1990 to 2013, there's a fall off in those suffering life-threatening injury from nearly 60% in 1990 down to approximately 30% in 2013. But when you look at our fallers from less than 2 meters, that was 4.7% in 1990 and is now almost 40% in 2013. There are limitations in this study. TARN came online and is now mandated that all patients with major trauma are reported to TARN. That has been since 2011. So undoubtedly, in the early phases, post-1990, not a great volume of patients were reported to TARN. But when these patients go back and you analyze data provided by the hospital episode statistics for those patients in that cohort in Plymouth, it did show year on year a marked increase in the elderly sustaining major trauma. Historically, we've tended to regard elderly care, the neck of femur patients particularly there, as one cohort of patients, and major trauma separately. But as you'll see, that as fractures are the common pattern of injury in our elderly fallers, we must now link all these chains together. And as I will come on to later on, very importantly, the role in hospital of the ortho-geriatrician, the elderly care physician, is increasingly important. So why do older patients have higher mortality rates? Well, firstly, they have poorer physiological reserve. They have pre-existing medical conditions. Often they're on many medications, and many falls are associated with timings of changing medication. And perhaps we're not good at triaging these patients, both in the pre-hospital environment and in the ED. Let's perhaps look at aging, if we may, in some detail. There are some common features. Loss of functional reserves, I've alluded to. Decline in organ function. The skeleton is more vulnerable to trauma. Low energy mechanisms now are more likely to injure the elderly person. And high energy trauma, such as the car accident I illustrated before, is more likely to prove fatal. Let's look at individual body systems, if we may, and in relation to the cardiovascular system, we all know that a fit person who becomes hypovolemic will become tachycardic and hypotensive and vasoconstricted and pale, etc. In the elderly person, they don't classically show those features of hypovolemia. They may well maintain a blood pressure, a reasonable blood pressure. They don't become necessarily tachycardic because their autonomic system is not working effectively. On top of this, add to a lack of ventricular compliance and associated heart disease, and therefore these elderly folks will only tolerate a relatively small degree of blood loss eventually before they suddenly collapse, as indeed was the case that I illustrated earlier. And I very much support, and if you take time away from this presentation tonight to look up online the Hector project, which is run by David Raven, who's done a lot of work looking at the pre-hospital care and assessment of the injured, as well as care in the emergency department and care on the wards. And his work makes very clear that deranged physiological parameters used to define cardiorespiratory distress may not apply quite frequently in the elderly. Let's look at the respiratory system now, and I'll begin by relating this to a patient I've been involved with in the last week. A lady of 78 who was brought to the another ED department by her daughter as she'd had a fall. She fell against the edge of a table and had local tenderness on the chest wall. She was examined, a diagnosis of a muscular strain was made, and she was sent away, despite, according to her daughter, showing some features of increased respiratory rate, as she took her to the hospital about 48 hours after injury. This patient then re-presents in the hospital where I work and was admitted with pneumonia and had a very stormy, and was having a stormy passage in the intensive care unit at the moment. So in relation to the elderly patients, we have to be very careful of minor chest injuries, because many of these need appropriate inpatient care and pain relief physiotherapy to avoid life-threatening complications, which are predominantly due to infection. So all of this is because there is increased chest wall rigidity, there's loss of muscle mass, there is reduced alveolar surface for gas exchange, and once again, the demonstrable signs that you'd look for of hypoxia and hypercapnia may not be visible in our elderly patients. Central nervous system is again very interesting. As you get older, your brain shrinks in size. There's increased fragility of the blood vessels on the surface of the brain, and many of the patients are on aspirin, warfarin, or some of the more modern non-vitamin K reversible oral anticoagulants. So what does this mean in terms of our patients? It does mean that if it was you as a 25-year-old fit male who had a bang on the head and some early intracranial bleeding, very soon you will show signs of a pressure effect in the brain, with a change in your level of consciousness, and over time changes in your blood pressure and your pulse, and eventually pupillary signs. In the elderly, because there is space because of shrinkage of the brain, then that becomes a very late feature. So often, therefore, many of these patients have catastrophic head injuries, but may not have a significant, if any, lowering of their Glasgow coma score. Just a reminder that if you were looking after a motorcyclist RTC or a young person with a head injury, then we would classify, based on Teasdale's work, a minor head injury as a GCS of 13 to 15, a moderate head injury as a GCS 9 to 12, and a severe head injury as 8 or less. I'd like to now relate this to our elderly population as we move forward. And the first thing to say is there are sufficient papers that show that GCS does not reflect the anatomical injury in the elderly, and they invariably will present with a higher GCS. The common pattern of traumatic brain injury in the elderly is that females are more common than the elderly. They're invariably low energy falls, and they are subdural hematomas, and those are that's due to venous bleeding on the surface of the brain. So the second landmark paper here, again, some of the co-authors are the same, again from Tony Kehoe as the leading author from Plymouth, but they show very clearly that older patients have a higher GCS, and I'd just like to look at that in a bit more detail, if I may. So this again looks at TARN data. This is from 1988 until 2013. There are 25,000 patients. There are isolated traumatic brain injury, and there are two cohorts in this, the under 65 and the over 65. And if you remember the abbreviated injuries score, we're looking at patients with level 3, level 4, and level 5 injuries, which I will explain to you in a moment. So a level 3, it would be a patient with a fracture to the vault of the skull or the base of the skull, may have some brain swelling or a subarachnoid hemorrhage. A level 4 injury would have a subdural hematoma, bruising of cerebral contusion, and a complex skull fracture. And a critical level 5 injury would have a sizable large subdural hematoma, potentially brainstem swelling, potentially brainstem compression, or may have a penetrating brain injury. So from Kehoe's study, you'll see that in the under 65s, the average age is 37. In the over 65, it's 81. Of the more severe brain injuries, the AIS-5, then that occurs much more frequently, 40% in the over 65. But when you look at the mechanism of injury, draw your attention to the low energy falls. In the under 65 group, that's 21%, and in the over 65, that is 70%. And so these are guys with AIS-5 injuries, and in the over 65, they may be presenting with a Glasgow coma score of 14, and in some cases 15. So apparently no significant change in level of consciousness. And to summarize that point again, the ISS-5s in the over 65s, then you can see that the mean GCS is 14. And the mortality, needless to say, is considerably greater in the over 65 age group. Very interesting that you may think in many of these elderly people that treatment is potentially futile, and that's not the case. That in 32% of the over 65s with multiple injured with head injuries achieve good results. If you look at the work, the second paper I've referred to here, these are the over 80-year group with appropriate early management. Then many of the majority achieve baseline functional recovery, so they're back to where they were before they were injured. And then Boris's work at the bottom for operative procedures in the 65 to 75-year-old age group for GCS greater than 8, then the outcome was as good as younger patients. We have, of course, to just build into this that many of the elderly have very significant comorbidity that may actually predetermine a poor outcome. So that said, these, all is not lost in these head injury patients, and as you'll see later, it's a question of getting a timely assessment and then onward discussion and probable referral to a neurosurgical capability to manage their intracranial bleeding. I commend you very much some of the work that's been published by Mark Wilson, a neurosurgeon in London, who gives some impressive figures for outcome in surgery in the elderly population. So some key points, if I may, about our geriatric head injured patients. So age is not proven as an independent factor of mortality. The predominant mechanism of injury is falls from a low energy. Beg your pardon, low energy falls from a standing height. And I dare say probably once or twice a week, you guys, if you're paramedics, are going to people who have had simple falls at home. And I hope following today, you will perhaps look more critically at some of these patients. We do recognize that the incidence of postoperative complications is higher in these patients, largely because of their past medical history. But for equivalent injuries, the 30-day mortality is the same. What we need to recognize is that for advanced age fallers, they do need a trauma team intervention. I'll come to that later on. And very importantly, there is a lower threshold for triage to a major trauma center, whether that be from the scene or that be a rapid transfer from a trauma unit to a major trauma center. And the other thing is that one needs a policy of aggressive resuscitation and monitoring, and then appropriate intervention to achieve better outcomes. I must also mention, of course, as always, let's not forget the vulnerability of this cohort of patients to both hypoglycemia and hypothermia. One reason why our elderly get very significant numbers of fractures when they fall over, one is due to osteoporosis, most prevalent in postmenopausal women, but also osteoarthritis or osteoarthrosis. This is because the joints are so stiff that when they fall over, you don't get much give around the joint, and you end up with a major long bone fracture because there's a shaft of femur or a tibial shaft fracture. I've alluded to comorbidity, and each of these has a significant role to play in potentially the outcome for our patients, as you can imagine. Smokers, diabetics, those with ischemic heart disease, patients with dementia, previous strokes and cardiovascular disease, liver and renal disease, and active cancer are all important comorbidity issues. Polypharmacy, again, people tend to fall when they've had a recent change in their medication, particularly in their antihypertensive medication, or they've become confused and they have missed medication, or in fact, they've had medication prescribed and they have a drug interaction. My paramedics listening today will know the importance of getting a good drug history and taking all medications with the patient to hospital. Let's now look at triage, if we may, and in England, then most people are familiar with the triage tool, which is based on anatomical injuries, deranged physiology, the mechanism of injury, and special circumstances. So in relation to the elderly, many of them don't actually have classical features of significant injury in terms of anatomical injuries. GCS 14 or 15 with a catastrophic head injury, difficult to detect chest injuries. In terms of physiology, they may seem hemodynamically very reasonable. Mechanism of injury, low falls doesn't normally trigger. And it's only really under special circumstances might you be looking at the over 55 group. And perhaps we need to visit this, because triage in the over 65 is as good as flicking a coin as to whether they've got life-threatening injuries or not. The work of Porter did show this, that the triage tool is at best 52% accurate and reliable in our elderly patients. And yet again, restating the point, the most common group that are under triage are the low energy mechanism of injury, particularly the falls from a standing height. So physiology, let's relook at this. If you've got an elderly person with a blood pressure of 110 or less than 110, then that's undoubtedly going to give you a poor outcome. And that person probably has got significant covert bleeding somewhere. And that should be a trigger for a very critical look at that patient and rapid assessment in hospital. And I'll just remake the point, this is another Keogh, this is not Tony Keogh writing here, but elderly patients, as I've said, present with a higher GCS for comparable injury severity in younger patients. So Calland, in his paper in 2012, wanted to change the threshold for triage in the pre-hospital environment. If you work in a major trauma centre, then you may well cringe when you look at this list, because the one thing we don't have in major trauma centres is the ability to take, as an example, all fallers from a standing height. But the suggestion from this paper was that age 65 and comorbidity needs a lower threshold for trauma centre, and I'd endorse that. Severe anatomical injuries in more than one region warrant MTC care. GCS less than 14 with a suspected head injury. Systolic blood pressure less than 100. Falls from any height with head injury, that might be the challenge just for capacity in the major trauma centres. Multi-system injuries, several long bone fractures after an RTC, And the next one that might be a challenge is the patient struck by a moving vehicle. So we need a system that is going to be able these patients, all of these patients, wherever they're taken to have appropriate initial triage assessment so that they get optimal care when their injuries are identified. So hypovolemia I've already alluded to, but with those physical signs, then there may be overt signs of blood loss, but otherwise you need to be looking to see or looking for the blood on the floor in form, or the blood on the floor is obvious, but could that patient be bleeding in the chest? Are they potentially bleeding in the abdomen? Could they possibly have a pelvic injury? Have they got long bone fractures? So here are the challenges then, actually. How can we improve the outcome for these patients? I think probably up front, and based on my own experience, I do think there could be a more robust pre-hospital examination of the chest in these injured patients, because I regularly see patients who actually do have quite obvious signs of chest injury that are not recognized in the pre-hospital environment. That said, we now need to have, I think, perhaps a system, call it what you like. I've called it here silver trauma alerts, but I think it means that whatever hospital, trauma unit or major trauma center that your patient goes to, that the patient should be assessed desirably within 30 minutes by at least a middle grade doctor. And that will go a long way to recognizing these patients who have potentially life-threatening injuries. You'll see from the paper I've illustrated here, it's been suggested that all Forglers qualify for this, and certainly all patients with head injuries and torso trauma. And I've certainly endorse the comments about torso trauma need very early looking at. How you deliver that, again, some have suggested having an abbreviated trauma tiered response. At my hospital recently, we had somewhere in the region of 14 elderly patients as fallers coming in a day, some having a fall secondary to urinary sepsis and confusion. That might be a challenge, but I think it beholds the medical profession now to ensure that we treat these patients appropriately and timely by whatever system the trauma unit and trauma network adopts. One thing you can do, some of you may have point of care access to lactate measurement, and early work has suggested that elevated lactate in trauma is something to look for if you can, which may suggest triage to a major trauma center. I just wanted to make one or two other comments in relation to the elderly, if I may. The Faculty of Pre-Hospital Care is due to report on its work on spinal immobilization. Many of you, I think, will probably be pleased to hear that the collar is going. And all of you, I'm sure, in the past, when you've tried to immobilize the elderly with any of these conditions, have met a challenge. And my take on this is that even excepting for someone who may have dementia, if they are essentially awake, they will have normally protective muscle tone, and they're unlikely to come to any harm without formal immobilization. I just want to talk a little bit now about how our pre-hospital care may impact potentially on some of the complications that occur in hospital. So when we start looking forward to the recovery phase for our fallers, then care has to be very bespoke and patient focused. That's taken, but that means in-hospital attention to detail, making sure the patient has the medication that they were prescribed before. Often there's a time lag in getting that written up. Also, that there are no potential drug interactions. We need to look at the risk of delirium, and of course, the sooner we manage the patient's injuries and can get the patient mobile, then the risk of hospital-acquired pneumonia drops. Again, just a hospital comment that you bring a patient in. I'll just pick a patient as a neck of femur as an illustration. The patient goes in, is starved overnight to go on the next day operating list, but then is bounced by a major trauma coming in. and the patient starved all day, they're then starved, they have something to eat and drink, and then starved the next day. And that sort of pattern of practice invariably leads to significant renal impairment and compromised outcomes. So we within hospital practice can impact on that. And certainly 7-day working in trauma and orthopedics and in the major trauma services now has had some impact on the quality of recovery many of our patients may make. But let's look at delirium, because it is a major cause of morbidity and mortality. Many patients you pick up may well have signs of delirium, particularly if they've been lying on the floor overnight, or they have, say, urinary sepsis that's precipitated a fall. So in the elderly over 75, it can affect between 20 and 80% of our patients, with a 2 to 5 times increased mortality, increased length of stay, and increased time and challenging to discharge. Delirium is typified by fluctuating levels of consciousness, and the patient may be hyperactive or hypoactive. And the pinch me mnemonic comes from David Raven's work again with the Hector project. If we leave patients in pain, that's more likely to be associated with delirium. If we fail to manage their infection, if we fail to manage their hydration or manage their medication, or in hospital after opiates, quite commonly allow them to be constipated, all of these things influence the patient's developing or the magnitude of a delirium episode. So collectively, we need, I think, to be much more aware of these challenges. We are currently failing our elderly trauma patients using ATLS and the European trauma course, as we're not addressing many of these issues for inpatients. Certainly, we have to consider a multidisciplinary and a holistic approach to get better outcomes for our elderly patients. So what is the way forward? It's really got to be better pre-hospital triage. I think that probably needs a more careful look at some of these patients. And it has to be an agreed network response. So within the West Midlands, where I work, we're trying to ensure that whether your elderly faller from a standing height goes into a local trauma unit or into a major trauma centre, they get the same level of silver trauma response, unless, of course, they are a proper trauma alert going to a major trauma centre. The next thing we must do is lower the threshold for the traumagram, the CT scan from the head to below the hips. And we are running a series at the moment looking at doing traumograms on all patients with evidence of head trauma. There needs to be earlier consultant input, including an orthogeriatrician. And some of you will be aware that there is a financial incentive to manage our fractured neck of femur patients once in hospital by getting them to theatre within 48 hours and certainly by 72 hours. And if we could only give the same attention to our elderly fallers as we do to our fractured neck of femur patients, then the outcome would be better. The other important thing in the elderly, we've just had a patient, 93, with multiple chest rib fractures and associated fractures, taken to HDU, optimized, early interventions, and the patient has progressed well. And I think, early aggressive management is something which, as hospital practitioners, we should be looking for. Here's a cautionary note from the paper from Hillebrand and others, published in 2016, that if you are an elderly faller, then your mortality is 3 times higher if you stay in a trauma unit. And that's why I think if patients go into a trauma unit, they need that rapid assessment, that rapid CT scan, and then appropriate transfer to a major trauma center if there is something that can be done for their injuries. Unfortunately, we're not in a position, as I've said before, for all of our elderly fallers to be transported increasing distance to an MTCs unless there are clear indications to do so. So our pathway of care, I think, is good for our elderly trauma patient. Many are going to be primary bypass when they tick your triage tool. Some will go into a local trauma unit, and if they deteriorate and if they can be helped, there will be a prompt secondary transfer to the major trauma center. and we are reliant on repatriation to get our patients from the major trauma centre back into their local hospital. Care nearer to home where family can visit easily is so very important. And hopefully we can couple all that with the Falls community programme and try and restrict the ongoing problems of the elderly fallers. So this guy, I think, is lucky in two ways. Firstly, he's 86, and he has run a significant number of marathons. And secondly, he's supported by a member of his family there. But the important thing here is this guy is physiologically fit, but like anyone else, okay, his bone age and bone stock may be good, but he will have aging changes, and should he fall over and get injured, then he may not show the overt signs that we tend to see in younger patients. But he does deserve, as most of our elderly patients do, to have that initial proper assessment and an opportunity for appropriate surgical treatment and treatment in a major trauma centre if that is going to improve outcome. I'm going to finish here, but I would be very happy to take questions. My final comment is that in relation to trauma care, if you are from a company listening in tonight, we are very keen to get sponsorship for our continuing webinar program. And at this stage, I'd like to hand you back to Andrew Ormrod.
Thank you very much, Professor Porter. We have got some questions, and we have got some people who would like to ask the questions live. So I'm just going to pop over to my screen. I think we've got some written questions. Sarah, have you got some questions for us?
So Teresa's asked, is there a difference in signs and symptoms between a patient who has a slow bleed to the brain compared to a patient who has dementia and both appear confused?
Yeah, it's always a very difficult, isn't it? Because there may be very little to show in that patient who has a slow bleed, perhaps a little bit of confusion. What I tend to do in those patients with dementia is to speak very much in depth with their carers, because they probably are able to relate changes that have occurred in the patient. And if there is any question, then these patients are all going to need a CT scan of their head.
That's great, thank you. So we have another question from Rebecca, and Rebecca's asked, could there be an adaptation to the GCS like for PEDS GCS, perhaps silver GCS?
You're absolutely right. So, I mean, some major trauma networks have, since 2011, modified the criteria for taking patients to major trauma centres. It used to be GCS 14. In some, it's down to 13 now. In the elderly, it actually needs to be reversed. I think this is a big challenging area, isn't it? Because I was looking at some data, I think from Harrogate recently, showing a very significant number of patients in that sort of area there are on some form of anticoagulation. So you have patients who fall over and bang their head, who maybe GCS 15 may not actually have lost consciousness, but over time, as a consequence of their injury and of their anticoagulation, they get a bleed. So I don't think early on you're going to actually gain anything by having a variable, a new GCS for these patients. What it is actually being absolutely alert to the risk that this patient may be developing significant intracranial bleeding. The NICE guidelines are very helpful in this situation.
We have got another question that's just come through from Dave Hartford. So, as a CFR, we get called to falls in the elderly quite a lot. Where GCS is used for paramedics, etc., it can be somewhat confusing for CFRs who don't get that in-depth training. Do you think we could use AVPU to triage while waiting for the crew?
Yes, I think so. I was instrumental in actually setting up AVPU many years ago with colleagues, and it does show some crude changes, obviously, alert, responding to voice, responding to pain, or unresponsive. And clearly those patients particularly at risk is when, if they go from a V to a P, because that usually relates to a valid Glasgow coma scale of 8, the definition of coma, and where patients are going to be at risk, particularly of airway compromise. So if you are not familiar with GCS, then certainly AVPU, but it's actually looking at the change in the patient's status. I mean, more patients get better than get worse, but to actually be able to say at a set time, these were my observations, and 10 minutes later, this is their changing status, I think will be very helpful. And if someone is deteriorating, that probably is an indication they should then be transferred to a major trauma centre.
Thank you. We've got another question from Russell Murray. You mentioned that silver trauma patients would benefit from a more thorough chest examination. Can you explain in more detail what you mean by this, please?
I can certainly. So I've seen quite a lot of patients where the no problem with the chest has been identified in the pre-hospital environment, but a hands-on examination feeling the ribs has demonstrated chest wall tenderness, which in an elderly person invariably following a fall is going to equate to fractures, and then potentially underlying complications such as lung contusion, pneumothorax. And I think it's just making sure that you adequately expose the patient to examine the chest. I appreciate we don't need them exposed for long because we need to keep these patients warm, but I think we could probably do more meticulous chest examinations.
Thank you for that. So we have another question from Rebecca Miller, and Rebecca's asked, what would your top tips be for paramedics attending these jobs pre-hospital?
They're a challenge for everyone, and I have every sympathy with our paramedic colleagues because, same as in hospital, we don't get it right for many of these patients. We think they're all right. They turn out to have more significant injuries. I think our paramedic colleagues working within their local trauma networks need to agree what is the best policy for where patients should go to and criteria for early reception and early transfer, early scanning. I don't think there are any real top tips other than be aware that patients, our mature patients now quite often have life-threatening and life-changing injuries, but may not show the physical signs to support that initially. So, falls from a standing height, I would think after today, people will probably look, I would hope, a little bit more meticulously at them from a clinical assessment point of view.
Finlay, can you hear us?
Yeah, can you hear me?
Yeah, would you like to ask your question to Professor Sir Keith Porter?
Yes, please. So ambulance services have a really big thing at the moment of you need to go to the nearest A&E, obviously barring if indicated by the trauma triage tool. Because you've mentioned this isn't as effective in the elderly as it should be, will Trauma Care be working on development of a new one? And if so, will it have paramedic input into it?
Moving forward, yeah, I mean, as you look towards changing systems, then it needs to be inclusive in terms of representation, and very much paramedics are on board. I alluded to the work going on at the Heartlands with the Hector project, and from the pre-hospital point of view, then paramedics are involved with that. I work in a major trauma centre, and we spend most of our time nowadays trying to generate capacity because we are pretty full all the time. And that's actually because of a failure of the social care budget to get patients out, which means we can't get patients out of the ITU, which means from A&E we can't get patients to the ward or to ITU, which means ambulances may be queuing outside. So really the last thing we probably need following my talk tonight is all elderly fallers ending up in an MTC because there isn't the capacity. I know some hospitals in London are independently looking at this because they truly have major capacity issues because of this cohort of patients. So what it is, I think, is that for those who trigger the tool or you have a reasonable index of suspicion, yes, they should be in the MTC. It beholds the other hospitals in the trauma network to assess that patient timely at a senior level of doctor, have an early CT scan, and identify those life-threatening injuries, and then transfer appropriate patients from the trauma unit to the MTC.
Thank you very much indeed, Finlay, for that question. That's a good question. We just have one more question that we can take from Steve. Are you there, Steve? Can you hear us?
Yes, hang on.
We can hear you now, Steve. You want to ask your question?
Okay, go ahead. Yeah, go on, Fran.
I'll ask it if I may. Well, actually, it's a comment, if I may. We're CFRs in a wild rural location, and quite often our patients have to wait a longish time for the ambulance to arrive. So we just want to thank you, Professor Sir Keith, for a really helpful, thoughtful presentation that we're going to bear in mind if we go out to anyone. Thank you.
No, you're very kind, and I appreciate your comments. And I'm sure at next year's Trauma Care Conference, we will be addressing this issue in probably all fora, because it is absolutely topical. So thank you for your comments.
Thank you very much indeed. Unfortunately, we don't have time to answer any more questions live. I can see there is some more questions that have been sent via text, and so we will try and get them questions answered by email, hopefully in the next 48 hours. Before we wrap up tonight's webinar, I just want to point out the next two free CPD webinars that are coming up. The next one is on the 27th of April 2017 at 8 o'clock. I know there has been some confusion over the times of the webinars, and I have seen lots of people try to get on later on. So all the webinars will be at 8 o'clock at night, presented from Trauma Care. The next one is the pre-hospital management of pelvic fractures, and that's presented by Dr. Caroline Leach on the 27th of April. So you can register for that now on the Trauma Care website. And then the one following that we have organised up to now is one on the 8th of June, which is traumatic cardiac arrests, and that's by Professor Jason Smith. All that I need to say to you is, for those people who are a member of Trauma Care, you will get a CPD certificate that will be issued to you for tonight's webinar, and the recording of this webinar will be available on the Trauma Care website within the next 48 hours. Do you have anything to add to that, Professor Porter?
No, thank you very much for facilitating this. If I could just tell the audience of one other webinar, which we don't have a date for yet, but I think is very, very important. Sadly, based on the experiences in London last week with that horrendous stabbing and terrorist incident, I have invited Professor Tim Hodgetts, Brigadier Hodgetts, to present a webinar on citizen aid. And this, I think, will be attractive to all, even whether you have a medical type background or otherwise. So we will publish the date of that webinar fairly soon.
Absolutely. If you have got access to the internet, I have just popped up on the screen the Citizen Aid website, so it is most certainly worth going and having a look at. Thank you very much indeed, Professor Sir Keith Porter, for tonight, and thank you indeed to Andy Thurgood, who's there with Keith just to support with the technical side. Thank you to my colleague Sarah Harris, who's helped with the questions on the social media, and please do jump over and visit the Trauma Care website, because we have got the CPD events that are available to be booked onto. Literally jump onto the website, click onto CPD events, and you have got the next two webinars which are listed there for you to book onto. So thank you very much from me and from the team from Trauma Care. And if you are working this evening, stay safe out there, and thanks very much. Goodbye.